Well, welcome back from break. I show we have about 30 seconds left, but there we go. It's 11 a.m. Pacific time. I wanted to thank everyone for such an amazing morning, our speakers and sponsors and moderators thus far. And also, I'm really excited about this next half of our day. Our next panel is going to address gaps in maternal mental health education, provider education, and also solutions. And I'd like to introduce our moderator for the session, Sue Kindig. Many of you in the maternal health space know Sue and her work well. She's a board certified women's health nurse practitioner. We're actually working on a webinar together on the role nurse practitioners can play in maternal mental health. So stay tuned for that later. But for purposes of today's panel, we'll be focusing on a different set of providers that many of who we've heard about already in today's session. And Sue, in addition to being a women's health nurse practitioner, is an attorney with 4 decades of experience as a clinician, educator, and strategist. She has worked to develop behavioral health home and other value-based care initiatives. We'll be talking about value-based care tomorrow on another panel, and has led development of maternal health AIM bundles, including the first maternal mental health bundle, which I presented in our last session, and there's been a recent update, which I shared the recommendations on as well. Sue, welcome to you. Thank you for all of your work in maternal health care, and welcome to our other panelists to the main stage. I'll now turn it over to you.
Great, thank you, Joy, and it's a pleasure to be here talking about this really important topic. And I would like to ask each of our panelists to introduce themselves briefly, starting with Tiffany.
Good afternoon, everybody. I'm Tiffany Moore-Simus. I am a general obstetrician gynecologist, the chair of OBGYN at UMass Chan Medical School, UMass Memorial Health, and have co-chaired ACOG's expert work group around maternal mental health for a good number of years now.
Great, thank you. And Lauren?
Hi, everybody. My name is Lauren Osborne, and I am a reproductive psychiatrist, but I serve as the vice chair for clinical research in an OBGYN department at Weill Cornell Medical College. I conduct research on the biological mechanisms of perinatal mood and anxiety disorders, and I have a big education hat as the chair of the education committee for Marseille of North America, and also the chair of the National Curriculum in Reproductive Psychiatry, which is affiliated with MONA.
Wonderful, thank you. Angela?
Hello, thank you so much for inviting me and the Association of American Medical Colleges, AAMC, to be here today. My name is Angela Blood. I'm the Director of Curriculum Research and Advancement for the AAMC. I'm a PhD social scientist and educational researcher with a focus on learning science, curriculum instruction and assessment, and program evaluation in health professions. This is an incredibly critical topic, and it's important to me personally, so I appreciate being included. In terms of what I do, I support institutions and educators in building common resources, providing platforms and events for learning and connection, and providing data to make evidence-based program change decisions.
Great, welcome. Birdie?
Hi, I'm Birdie Gagnon-Meyer. I am a nurse and a therapist, and I'm also certified in perinatal mental health. I worked at a large hospital system and started in Indiana, and I started a perinatal mood disorder program there, ran it for over 25 years, and I retired from there in 2018 when I was then hired as staff to start a perinatal mental health certification, which I did. And also now I'm the director of certification and training. I also serve on the maternal mortality review committee for Indiana and have been doing training for PSI since 2006. So I have been affiliated with PSI for quite a while. Glad to be here.
Thank you. And our Andrea, can you introduce yourself?
Hello, I'm Andrea Clark-Horton. I am the director of the Perinatal Mental Health Alliance for People of Color. Bertie is my colleague there at Postpartum Support International. I've been in that role for about 2 years, and I come to this work after 6 years of hospital chaplaincy, concentrating on women's health. doing a lot of work with families experiencing loss and infertility. And I'm currently a PhD student in religion and psychology. And my research is going to focus on the intersection of faith and perinatal mental health and how faith communities support perinatal individuals during the perinatal period.
Well, thanks for all of your work, everyone. We have quite a impressive panel. I'm going to move into the questions because we have limited time. So I'm going to ask each of you to please tell us more about your work and developments in maternal mental health education respective to your individual work. And let's start again with Tiffany.
So, in medical education, especially along the physician track of medical education, we often refer to three major time points. One is undergraduate medical education, which is medical school. Second is graduate medical education, which is residency, so post medical school training, but before you're board certified in your specialty. And CME, or continuing medical education, which is you finished your training, but you need to remain current and competent as things evolve and change. And so I'll focus a little bit more on CME. And so in the last session, I talked a little bit about the work ACOG, the American College of OBGYN, has done around creating clinical practice guidelines. So clinical practice guidelines are a way to put evidence-based practice in documents and in a way that is a go-to for people who are out in practice. The other, for anything that's a clinical practice guideline, it also is the potential for content and things like board certification exams and maintenance of certification processes. And so as ACOG put those clinical practice guidelines together, also partnered with us and our team at UMass Lifeline for Moms, and also posted toolkits, implementation guides, and a e-module. So it's a 2-hour self-paced, interactive, case-based learning opportunity that is available for anybody who wants to get CME credits. In addition, Sue Kendig led the original AIM bundle around perinatal mental health, and there was a update of that was published in this past year. And those bundles come along with bullets on what to do, but also a lot of resources on how to do it, implementation guides, webinars, an IHI change package. So each one of those resources I consider as potential educational resources, not just for those that are already out in practice. They certainly can be utilized by people in UME and GME, but really were designed with a very purposeful input and to help increase the capacity of those that are already out in practice to address perinatal mental health.
Great, thank you. Lauren, can you tell us a little bit about recent developments in your work?
Absolutely. And Tiffany gave me a nice opening by explaining how the three sectors of physician education work. I'm also coming mostly from the perspective of physician education and also generally other people who prescribe in this period. My work has mostly been focused on residency and post-residency fellowship education. So I am the chair of, as I mentioned, of the National Curriculum in Reproductive Psychiatry, which was a grassroots effort. We started working together about 10 years ago. And we have now created a curriculum that was designed for psychiatry residency education. And it is downloadable guides in 13 different subject areas that are posted on a website for anybody to be able to teach reproductive psychiatry within a residency program. You don't have to be an expert in reproductive psychiatry to teach it because we give you all the answers. And the reason we started this project is that psychiatry residency and OB-GYN residency require essentially no training in reproductive psychiatry. In OB-GYN, there's a couple of mentions about you ought to be able to know how to diagnose postpartum depression. In psychiatry, there's no mention of it at all. So there is nothing required by the Accreditation Council for Graduate Medical Education. So we came to this thinking psychiatry residency programs need to have this information. And what we've discovered is that a lot of other people also want this information, but they don't necessarily want it in the same format. Psychiatrists are happy to read long PDFs with, intensive case descriptions, and OB-GYNs may be a little less so. So we have now developed a number of offshoots. One is an adaptation of this curriculum specifically for OB-GYNs that'll be posted on our website this coming spring within the next couple of months. We also do a 3-day CME event for people who didn't learn this in residency and still want to learn it, for which you can get continuing medical education credits. We've published a textbook, the American Psychiatric Association Textbook of Women's Reproductive Mental Health. And then as an offshoot of this CME exam, we've now developed a year-long peer supervision group that people are eligible to do if they've done that CME course, and then a clinical skills exam, which is an oral exam that people take at the end of that supervision course. So they'd have the CME exam, a year of supervision, and then a clinical skills exam. And all of this has sort of pushed us also toward thinking about the fact that we don't have board certification in reproductive psychiatry. And Marseille of North America has been instrumental in forming a task force to address that question, decide, do we need board certification? If so, what format does that take? And we are on the verge of announcing the members of the task force, which includes representatives of Marseille of North America, Postpartum Support International, and the North American Society of Psychosocial Obstetrics and Gynecology. And we'll be working on that question of board certification very actively for the next couple of years.
Thank you. Lots going on. Angela, would you like to add to the conversation?
Yes, those are really good summaries and good lead-ins. So I'll try to keep it relatively brief and not duplicate. But from my perspective, maternal health in general needs a greater focus. So in that context, and as a mother, I experienced some issues in access in this space, which I've shared publicly on LinkedIn, and I published a commentary, so I feel safe saying that. So I'm glad to be with the group today. We're seeing a lot of progress in this space, but there's a lot more that needs to be done. In terms of what the AAMC is doing in the space, I included some select resources in the handout provided because there's more to talk about than we have time to delve into. But the best place to start is the AAMC Maternal Mental Health website. There's AAMC resources as well as external resources. There's a 5-part learning series. It's free to access and register. There is data available, an easy to access infographic, a 1-pager summary, and a research brief for those who are interested and want to dive deeper into the analysis and methods. And a grant opportunity is when we talk about what needs to be done and what can be done, support and funding is key. So I wanted to lift up this second annual award. It's for AAMC member institutions working to make mental health care access more accessible for everyone. And it's due April 12th, which is coming around. So if you're interested in that, please check out the link on the handout, which has the information and the application form. And I'll leave it there for now because we can dive into a little bit more later on.
Great, thank you. Birdie?
Sure. Hi, everybody. We, like I said, I was hired to start a certification program in perinatal mental health in 2018. And I actually started in 2017, now that I think about it. The first test was given, certification exam, in 2018. And it's the first time in my life I've ever worked with psychometricians or even heard that word, because we partnered with Pearson VUE and to develop the exam and look at the entire process of what does that mean to be certified. So just a really quick, if you look around for someone's, let's say a therapist or someone who prescribes, or even a doula or an OT or PT, none of them, as the others have said, no one in higher education has received anything on perinatal mental health. But there are people out there that say, come see me, I specialize in perinatal mental health. And they may have taken 1 hour of training or maybe nothing or read a book. And so the certification actually says, yes, this person has had foundational training and advanced training and has been in the field at least 2 years and took an exam and passed it. So it really says a lot. And we're hoping, that keeps getting bigger and bigger as it is. So since 2018, we are now up to 4,900 people that have the PMHC. So that's nearly 5,000 people. It's really like a dream come true for me. And that is in US and Canada mainly. and then 21 other countries. We're doing 5 virtual trainings this year, the foundational training and the advanced. They come from all over the world. It amazes us every single time. The majority of who comes to trainings and who is certified in perinatal mental health, you can only imagine, is about 80 to 85% those who are mental health therapists, counselors, psychologists, and then the other 40% is it's a little bit more in the track for those who prescribe. And so 20%, maybe 25%, and then maybe 15% are the other, which is the affiliated track, OTs, PTs, doulas, nurses. So nurses who don't prescribe, just bedside nurses, and that great area of nurses, go nurses. So knowing that, and that the trainings, and I think what's really new with PSI is we just keep adding more advanced trainings in this field because people want more and more, and that is that we've added a perinatal loss 2-day training. We've also added a dad's paternal mental health training 2-day, and we are working on right now substance use disorder and perinatal mental health, since of course there's the 2 top reasons for maternal mortality. So I think that's all. I was wanting to make sure I said it all, but we have trainings. So check out, I gave you a handout on the certification and how that really works. And on there, you should be able to go to a link to see all of our trainings. We go in person in different places, and we also do virtual. So join us, become certified, and that's all I'm going to talk about right now.
Great, thank you so much. And I just want to point out that we are putting links to some of this in the chat, the certification and the AAMC program and so forth. Andrea, do you want to wrap up this question with some updates on the work that you're doing?
Sure, forgive me. I've come down with a cold, so I'm hoping my voice will hold out. So as I mentioned, Bertie and I are colleagues at PSI. And so one of the things that she mentioned is finding people who actually have a depth of expertise in perinatal mental health care can be challenging. And so if it's challenging in general, then to find BIPOC providers who are certified in that area is especially challenging. And so one of the things that I started when I came on board is a professional mentoring program for BIPOC providers who are interested in certification. And so that works as a group mentoring model with they're mentored by a BIPOC provider who has gone through and successfully completed the certification process. They serve as kind of study groups for one another, but also what we know is that for a lot of BIPOC providers, they are or may be one of the only folks in their space that look like them. And so it also serves as a way to build community amongst our providers, and so that they're feeling as though they're not necessarily alone as they journey toward certification in this specialty. The other thing that we're going to start for the very first time this year is we're launching an Alliance Fellowship program. So for BIPOC providers, and it can be from the allied professions, it can be from prescribers or therapists or anyone in the mental health field. It's going to be a 12-month fellowship program where we are really looking toward developing the next pipeline of experts in this area who seek to kind of deepen their understanding of perinatal mood disorders. It's going to provide a centralized space for them. So they'll gather together at least once a month, and it'll provide a centralized space for them to find and get information on not just perinatal mood disorders, but how they look and how treatment looks different in communities of color. It'll also give them space to think creatively with one another about where the gaps are and how to fill those gaps, because one of the things we're going to ask of our fellows is that they're going to pursue research. We know that research and publication informs practice in all clinical spaces. And so our desire for our fellows is to then publish findings, findings with recommendations about where the gaps are that they've identified. They'll focus on a specific issue, and then they'll be responsible for coming up with a capstone project that we hope will be publishable, so we can continue to influence practice with regard to perinatal mental health and BIPOC communities.
Thank you so much. I'm going to move on to our next question. As you know, we have 4 different categories of participants: payers, philanthropy, providers, and policymakers. So I'd like to ask each of you to choose 1 or 2 of those participants and talk about what they could do to help advance your educational initiatives. And Lauren, this time I'm going to start with you.
Sure. I think it's hard to choose because I think there's so much that everybody can do in all of these areas. But I really want to focus a lot on the payers and on the policymakers. And hospital systems rather. So the payers, I think the biggest thing that payers can do is equalize reimbursement for mental health care. It's hard to get across our message about education if people aren't incentivized to provide that care. And with the reimbursement rates being so much lower for mental health care than for any kind of physical health care, what that means is that a lot of psychiatrists and a lot of therapists don't take insurance because they can't pay their rent if they rely on insurance to reimburse them. And what that has led to is a culture of mental health providers not taking insurance, and also a culture in which OBs are really not incentivized to see a patient for a mental health reason, because we have this bundled care for pregnancy and postpartum, and that additional time to see a patient for a mental health reason just isn't optimal. And so I really think we need to pay equal time for equal pay for equal worth. One of the things I say to my colleagues here in OBGYN as the lone psychiatrist in my department is that I'm working just as hard and I'm spending just as much time with my patients, but they're getting paid a whole lot more for that. And that just can't go on if we want to actually tackle this. And our education efforts are going to fall flat if we don't have those kinds of incentives. And then I think on the side of sort of combination of policy makers and hospital systems, why don't we require continuing medical education in reproductive psychiatry for licensure or credentialing? Right now, I have licenses in 2 states, New York and Maryland, and in both of them, I have to take 3 hours of continuing medical education in opioid prescribing before I can renew my license. I almost never prescribe opioids. It's not really in my scope of practice, but I know really well how to do that. And yet the things that are in my scope of practice, I'm not required to have continuing medical education for. So I think psychiatrists, OBGYNs, family practice docs, anybody who's a frontline clinician who's going to encounter our women with perinatal mood and anxiety disorders needs to be educated, and we need to require it. And I'll stop there.
Thank you. Tiffany, I'm going to go back to you.
I would like to sort of lift up and maybe add some additional nuance to some of what Lauren said. When we talk about reimbursement, we're not, nobody's looking to profit here, right? We're looking to provide the services that are necessary. And if you look at the evidence in the literature, say most perinatal individuals would actually like to receive their mental health care in an obstetric care environment as opposed to a psychiatric mental health environment. And yet how to make that sustainable in OBGYN offices is really important to be able to address that. When you look at some of the education, like the clinical practice guidelines, it focuses predominantly on the prescribing piece because that's what the obstetric care clinicians are likely to do. And because they are prescribers, they are less likely to be the therapist. And that is first line and critical into really being able to support that in that environment. I think the other thing is, we have to recognize that there are generations of practicing individuals, clinicians who are caring for pregnant, postpartum, and lactating individuals who did not train in this. So programs like perinatal psychiatry access programs, certification programs, what have you, continuing to support those, which is both policy and philanthropy. If you look at the perinatal psychiatry access programs across the country, many are supported through HRSA, but it's for a specified period of time, right? There are some access programs that got funded and then lost their funding. Such a waste of time and energy when it's so needed. And then there are other programs that are funded through state money or foundations, philanthropy, et cetera. So really trying and knowing that there are generations of providers that did not train in this, supporting those types of solutions to help increase the capacity that those that are out there really want to do, and helping them do that, I think is really important. And I could continue, but I want to give my panelists, my co-panelists, an opportunity.
Thanks so much. So lots for our philanthropy and policymakers to be thinking about. Angela, would you like to add to that?
Sure, thank you. I think this could apply for providers, healthcare systems, professional societies, and policymakers. Now, we know incentives are very effective in driving momentum. There are enthusiastic educators who want to tackle this work, but they need the resources to support them, including grants. From an educational perspective, we need to continue to fund and ergo value educational work and research in this area. This includes publishing, curriculum, learning, assessment for all healthcare professionals. And I provided a selection in the handout, but there are gaps in the literature just waiting to be filled. And sharing our lessons learned, including the raw educational materials, not just the summary data, in a scholarly way helps share the knowledge and avoid recreating the wheel, and build upon the knowledge so that ultimately interdisciplinary, interprofessional, and interinstitution scholarship in maternal mental health can be developed. We need resources that support the intentional integration of maternal mental health, like exemplars in threading and progressive responsibilities in curriculum design. This means curriculum that's integrated by design, not topics that happen to be sitting next to each other by coincidence. And in addition, clinician educators need their efforts recognized when it comes to dedicated protective time and promotion, so that their role as an educator is recognized and they're not penalized for dedicating themselves in this space. And as institutions build and innovate, they need the funding and the institutional support, including platforms and channels to share and collaborate with others. So while I'm focusing on education today, we need the clinical environment to support and reinforce what the trainees are taught in their learning. Learners need to see that their institutions not only believe in what they're teaching, but are modeling it themselves.
Fabulous points. Thank you. Bertie, can you talk a little bit about PSI's perspective?
Sure. Providers, you need to know about the trainings, take the trainings, and advertise the trainings. And I didn't mention earlier, we do have, for those who don't want to go through the whole certification track, we do have a medical provider training, which is a 4.5-hour training that's just an overview of perinatal mood disorders and then how to prescribe. And that would be for OBGYNs, for family practice, those seeing the people during pregnancy and postpartum, also for philanthropy partners to invest in nonprofits and give donations and scholarships to help those to attend training that may not be able to really do that. And then also just to have for the payers to have a knowledge of our PSI directory for those who have been trained, and give kudos to those who had training, and don't send them to people that haven't had training, because they can mess them up when they don't know. If the provider, whether that is someone who prescribes or a therapist or an OT or PT, if they don't know perinatal mood disorders, they can really mess up the person coming to them. So that's all mine.
Absolutely. Andrea, would you like to add to that?
Sure, I certainly echo everything that my co-panelists have said. And I think in terms of policy, Susan, you're a lawyer, I'm a lawyer too, among other things, right? And so policy and advocacy at that level is very close to my heart. And so there was a bill introduced in Congress in 2021, initially reintroduced last year, which Congress has yet to pass, but has bipartisan support. It's the Moms Matter Act, co-sponsored by one of my local Illinois Congresswoman Lauren Underwood. And this act proposes to do, well, it comes out of the recognition, one, that maternal mortality review committees on state levels have recognized that perinatal mood disorders and mental health disorders are a leading cause of death in maternal morbidity. And so one of the things that it also recognizes is that those communities of color, low-income communities, because of the additional stressors of just everyday life for folks who live with those realities, that they are likely to be more impacted. So this bill proposes to do two things. It proposes, one, to provide funding for training for those who work with this population to be able to treat substance abuse and substance use disorders during the perinatal period, but it also provides additional opportunities for grant funding for institutions and organizations that are going to do and develop some of the innovative kind of programming that we've talked about today to continue to educate providers on perinatal mood disorders, perinatal mental health, and providing support to that population during pregnancy and throughout the perinatal period. And so I think that it's important for our legislators, again, this has bipartisan support, right? It's important for our legislators to pay attention to the opportunities that they have in order to make an impact and to pass this, let's pass this act, let's get this thing done.
Thank you. You raised some really good points about policy that is out there, because in many of the maternal health bills, there are mental health sections, and it is important to keep watching that. Thank you. We have just under 10 minutes left, about 8 minutes. And so I'm going to ask one final question, and I'm going to ask you to keep your remarks brief. Do you have any closing remarks, anything that you want to leave our audience with? And I think I'll go in reverse order this time. And Andrea, start with you.
I had a feeling we are going to do that. Right. I think that I'm really grateful for this conversation. A lot of what my co-panelists said also stuck with me and stood out to me, especially in the area of providers finding these trainings, knowing that we're here, that we have the opportunities to be trained in these areas. They're here. But also for the systems and organizations that these providers work for to prioritize this as part of their continuing education. I think that that is absolutely important. And for me, as a practitioner of color, and as a person who works with practitioners of color across disciplines every day, to be able to have spaces where the training and education is focused on the populations that they work with every day is really important, and it's here. But we need the continued funding and continued support from across sectors to continue doing this good work.
Thank you so much. Bertie, would you like to add to that just briefly?
Yes, I'm just thrilled that we have this, and it's excited me today to hear all my panelists and that we're all on the same page. And I guess I don't have anything big and new to say really at the end. But everything we've said, please, please, please know that education is there. And this is so important with maternal mortality rates being so high. We've got to have more people knowledgeable in this field.
So our homework is to assure that everybody is aware of the certification and education that's out there. Angela, any final thoughts?
Yeah, so many thoughts, but to try to keep it brief, there are a lot of really good examples out there. It can be difficult to find an index journal that would impact more for promotion, that is willing to publish curriculum materials or assessment materials. But I'll do a plug for MedEd Portal, which does, and they publish across the health profession. So there are some good examples in there, like Mount Sinai Health System, to increase patient attendance at postpartum follow-up visits. They train medical students on a phone call project, and the phone calls made within 72 hours of delivery. The learners managed pain and screened for preeclampsia and depression and counseled on contraception and breastfeeding. And these kinds of things could be, even though it's published in the context of medical students, it could easily be adapted and applied to other learner groups. So, publishing that work, adapting it, and then working together. There's some very interesting, I have one medical school has a maternal health elective. It's designed for, but not limited to, students with a newborn at home so they can stay engaged in curriculum and learn some very timely skills. And allows the school to keep an eye on them and how they're doing. So that's the kind of curriculum that could easily be applied across other health professions. So just more opportunities like this for collaboration.
Wonderful. And I just want to point out that a curriculum like that also helps providers to understand and be empathetic when pregnant and birthing people are coming in and need to bring their children. So thank you for doing that. Lauren, would you like to add to this?
Yeah, I mean, this has been such a rich and full discussion, and it's, as always, it's exciting to hear about all the initiatives that are out there. I was recently speaking on a panel at the Society of Maternal Fetal Medicine and realized that most of the people in the audience had no idea of what educational resources there are. So I think the more we can do to promote that, the better. But really what I want to say as my final remarks, and I'm kind of prompted by hearing everybody, is I'm reminded of a question I had recently when I was at the NASBOG meeting, where somebody said, well, how do you reconcile your support for board certification for physicians with your claim that everybody in residency needs to know this, right? Aren't those contradictory things? And I don't think they are. The reason I got into this work was that when I graduated from residency, all of my fellow residents had only very dim ideas of how to take care of a pregnant patient, and they all called me to ask, and I realized everybody needs to know something about this. And I continue to believe that and continue to think that we need to push this in residency education so that everybody knows something. But I also think we're at the point where we need real concrete board certification for physicians, and Birdie and PSI have started that process with the certification that they have. And then I think we need to take that up to the level of board certification, because the moms that we treat deserve that, right? When I go to have a colonoscopy, I want a board certified gastroenterologist. So I think when you're dealing with a mom with a really complex perinatal mental illness, she deserves to be able to find a board certified physician. And I don't think those are contradictory things. I think we can strive for both of those things at the same time.
Thank you. And Tiffany, you have about, just a little over a minute to wrap us up. So final thoughts.
So many thoughts. What I would say is, in education, and not specific to medical education, people are often taught to the test. We are failing the test, right? Perinatal mental health conditions are the leading cause of maternal mortality, leading overall and preventable cause. We're failing the test, right? So we need more than that. I also this is a focus on education. I think there's so much more we can do in education, and also we have to acknowledge that that is never going to be the sole solution, right? This is much broader than this. And as a society, we have overwhelmingly underinvested in maternal child health. And right, social determinants of health, everything plays in here, supports, right? And if you think, I agree, Lauren, I'm all for certifications. I'm all for board certifications. And also we have to recognize that you don't have to be a therapist to be therapeutic, right? There's so much opportunity for us to support the perinatal individuals around us in so many ways that aren't just treatment, but also prevention. And so breaking down so many of the silos that exist to really address this, and really valuing the role that caregivers, especially women and children and other perinatal individuals, play in our society, can only get us in the right direction.
Thank you all for your comments. This has been really enlightening. And now I'm going to turn it over to you, Joy, to wrap it up.
Great. Thank you, everyone. I am taking notes frantically here on the side of my desk, and also just seeing so many of you today on the panel, the hard work, the years and years and years of work in developing education and solutions around deploying those educational resources. I just want to thank you on behalf of the field. Even though we hear there's more work to be done, we just need to pause and say thank you for your incredible efforts. Dr. Osborne, we've been talking about reproductive psychiatry for a decade, as you have pointed out, and great progress. And we're hoping to get even closer. And Tiffany, you acknowledged the board test and the work that the American Board of Obstetricians and Gynecology, perhaps a role that they can play in updating a test, for example. Just so much important work. Birdie, thank you for the PMHC designation at Postpartum Support International, and Andrea, the incredible work that you and your team are doing to ensure that Black, Indigenous, and other providers of color have the resources and support that they need. Incredible work all, and onward, and we will hope to check back with you next year or the year after on progress that's been made. Thank you. We're going to now pop up our Poll Everywhere opportunity to hear from you. What words really struck a chord with you during this session? You can text, I'm blurry there. Boy, there we go. You can find pollev.com/MMH to add your word or phrase with an underscore, or send MMH 237607 on your phone. And we will pop up some results here. Hopeful, that's a good one. Progress is being made and people are seeing some change. Collaboration. Maybe curious to know more. There are a lot of moving parts, I think we've learned in medical and provider education. Awareness about existing resources. I would probably add like mandates. I heard a few comments, I think from you, Dr. Osborne in particular. So interesting that certain types of education are mandated, but not yet perinatal mental health education. Very good. Well, we will save this word cloud like the others in our photos section in Whova.